Chapter 19 is about the heart. So the heart is part of the cardiovascular system, and the cardiovascular system consists of the heart and the blood vessels. The cardiovascular system helps us to deliver blood into the different tissues in our body so that they can have oxygen, nutrients, hormones, etc. And together with the blood, the heart, the blood vessels, they make the circulatory system. Within the circulatory system, we have two major divisions. We have the pulmonary circuit and the systemic circuit. The pulmonary circuit happens on the right side of the heart, while the systemic circuit happens on the left side of the heart. And within the pulmonary circuit, we carry blood to the lungs for having gas exchange and then return this blood into the heart. And in the systemic circuit, we supply oxygen to the tissues, and then the blood that is deoxygenated will return to the heart. So within the left side of the heart, we have fully oxygenated blood that comes from the lungs using the pulmonary veins, and then from there the blood will be delivered to all the organs using this aorta, which is the largest artery in our body. In the right side of the heart, we have handling of oxygen poor blood that comes from the inferior and superior vena cava, and then the blood will be sent into the lungs using the second largest blood vessel in our body, which is the pulmonary trunk. So this is a schematic showing you how these two circuits are interconnected. So here we have the pulmonary circuit that happens between this pulmonary trunk and then pulmonary veins, the lungs, the pulmonary veins, and then the left side of the heart. And then in here we have the systemic circuit that happens between the left side of the heart, the aorta, the capillaries within the tissues in our body, and then we have the returning of the blood using this superior and inferior vena cava. And in both circuits, we have gas exchange. Now the heart, it's an organ that is located in the area between the lungs that is called the mediastinum. The heart has a conical shape with the base pointing superiorly and a little bit towards the right side of our thorax. Then within the base of the heart, we have these large blood vessels attaching. And the apex of the heart is pointing towards the left side of the body and is tapered, and it has this specific location at the fifth intercostal space in the midclavicular line. In the adult, the heart weighs around 10 ounces. The base of the heart will have 3.5 inches in width, and from the base into the apex you have a length of 5 inches. And it is said that at any age the heart is the size of a fist. So this is the position of the heart within the thorax. So here we have, of course, the two lungs. This is the diaphragm, and this area in between the lungs is called the mediastinum. This will be the base of the heart that faces superiorly toward the right side. So this is the right lung, and this is the left lung. And here we have the apex, which faces inferiorly and into the left. If you are projecting the heart into the thoracic wall, the apex of the heart will be located at the fifth left intercostal space at the midclavicular line. So this is what I was referring to in the projection of the heart. So the base is located in here, and in here we have the apex at the 1, 2, 3, 4, 5 fifth intercostal space. Okay, and this is the midclavicular line in here. So if you make a section of the thorax like this, a cross section, and you see internally, you will be able to see that the heart is located here within the mediastinum, and the heart is actually located within this pericardial cavity. So the pericardial cavity is made by pericardium, which is a double wall sac that encloses the heart. And then in between these two walls of the pericardium, we have this pericardial space that it is filled with fluid, pericardial fluid. This pericardial fluid helps the heart to beat without any friction. So it provides some cushioning, because every time that the heart is beating, it is in constant contact with the internal wall of the thoracic cavity, and this can damage the heart. But thankfully, to this pericardial fluid, we don't have such friction, and then we don't have damage to the heart. Now, the pericardium anchors the heart into the diaphragm inferiorly and the sternum anteriorly. We have two layers of the pericardium. We have one that is called the parietal pericardium, and then we have another one that is external, that is the external, it will be the parietal pericardium, and then we have another one which is internal or deep, that is called the visceral pericardium or epicardium. The pericardial cavity, as I told you, it has this pericardial fluid, and it ranges this pericardial fluid in volume between 5 to 30 milliliters, and sometimes during some infections or inflammatory processes, this pericardium becomes inflamed, and then this condition is called pericarditis. So this is the details of the pericardium. So this is a double wall sac, and if you magnify this area and you see it in here, you will be able to see this pericardial layer, which is the parietal pericardium, and this is the visceral pericardium. The pericardium, it can be compared to when you have an inflated balloon, and then you put your fist into this inflated balloon, as you can see in this part, and then the actual rubber of the balloon that it is touching the fist, it will be considered the visceral pericardium, while this other layer of rubber will be the parietal pericardium. Now that we are here, you can see the other layers of the heart. So this will be the middle layer of or myocardium, which is made out of muscle, is cardiac muscle, and then you have this inner layer that is called the endocardium, which is made out of endothelial cells. If you recall, endothelial cells are simple squamous epithelium, so it's one single layer of cell, and these will be flat cells. Now, if you see here, we have the apex of the heart, and this will be the pericardium that attaches this heart into the diaphragm. It attaches indirectly, and anteriorly this pericardium, it will attach into the sternum. So again, this is just to show you the double layer of the pericardium. So this will be the visceral pericardium, and this will be the parietal pericardium, and in between you have the pericardial space or cavity filled with pericardial fluid. So the heart has three layers. The outer layer, which is the visceral pericardium, which is also known as epicardium, and then you have the middle layer, which is the bulk, which is called the myocardium, and then you have the endocardium. The epicardium is made out of a serous membrane, which protects the heart, and within this epicardium we have adipose tissue, and this adipose tissue helps to protect the coronary blood vessels. At some point, whenever you see this layer of fat outside of the heart, it is not bad. The bad thing, it will be to have fat inside the coronary blood vessels, because the coronary blood vessels will be the blood vessels that supplies blood into the heart. The endocardium which is the inner layer. It is continuous with the blood vessels, and as I told you, is made out of simple squamous epithelium. So it's a single layer of cell, flat cells, and this is known as an endothelium. Myocardium, the thickest layer. This layer is made out of cardiac muscle, so it's a specialized type of muscle. We will talk about the characteristics of this muscle in a few slides. And this layer of cardiac muscle will be proportional to the workload. The left side of the heart, they have to pump blood into a greater distance than the right side of the heart. So the myocardium on the left side of the heart will be thicker in comparison to the right side of the heart. Now, in the heart, some of this myocardium arranges in a spiral, and this helps to propel the blood through a ringing motion. Within the myocardium, we also have a fibrous skeleton that is made out of collagen and elastic fibers that helps to support the cardiac muscle and anchor the valves of the heart. And also it helps to provide electrical insulation between the atria and the ventricles, which is important to have a specific timing and coordination of the contractions of the heart. So this is pretty much the same figure that we saw before, just to show you again the layers of the heart. So this is the epicardium, which is also known as visceral pericardium. This is the myocardium made out of cardiac muscle cells, and this is the endocardium. And this figure, it shows you the spiral orientation of the cardiac muscle cells. So see how they make a spiral. This is the apex, this is the inferior view of the heart, and this is the anterior view. Internally, the heart is subdivided into chambers. So it has 4 chambers. The upper chambers are called atria, and the lower chambers are called ventricles. The heart, normally, it is divided into the left and the right side by walls inside the heart. And then we have separation then from the left side of the heart and the right side of the heart, and we have upper chambers that are called the right atria and the left atria, and we have lower chambers that are called the right and the left ventricles. Now the atria always receive blood, while the ventricles always deliver blood. The atria receives blood from veins, while the ventricles deliver the blood into arteries. Now the atria has little extensions that looks like ears that are called auricles. So this is the internal view of the segments or the chambers of the heart. So here we have the right atria, and here we have the left atria, and then below the right atria we have the right ventricle, and below the left atria we have the left ventricle. This wall that separates the 2 atria is known as interatrial septum. Inter means in between, and then septum means wall. In here we have the interventricular septum. So inter again means in between, ventricles, interventricular, and then septum. So this is the wall or the septum that separates the right and the left ventricles. Now, in between the right atria and the left atria, we have a valve. This valve is called the right atrioventricular valve or tricuspid because it has 3 leaflets or cusps. And then in here on the left side, we have the left atrioventricular valve, which is also known as mitral or bicuspid because it has 2 leaflets. These valves helps to deliver the blood from the atria into the ventricles without backing up the blood into the atria. So the delivery of the blood happens from the inside the heart happens between the atria and the ventricles. So you deliver the blood from the atria into the ventricles, and then these valves will open and close, and then when they close, they prevent the backing up of the blood. Now, at the endings of, or the superior portion of the ventricles, you have these valves too, which are called the pulmonary valve in the case of the right side, and then you have the aortic valve in the case of the left side. These valves have the same function. So once you pump the blood from the ventricles into the pulmonary trunk, which is this, or into the aorta, which is this, you don't want the blood to back up into the ventricles. You want to move always the blood forward. So this pulmonary valve and aortic valve prevents this backing up of the blood from the pulmonary trunk and the aorta back into the ventricles. So externally, the heart has some markings. It has the atrioventricular sulcus that separates the atria and the ventricle. And then within this sulcus, we have this coronary arteries running within this atrioventricular sulcus. And then we have an external layer of fat covering these coronary arteries, protecting them. Now, this atrioventricular sulcus runs a little bit horizontally, while the interventricular sulcus runs more or less vertically or a little bit angulated. And this interventricular sulcus is located at what it corresponds to the interventricular septum inside the heart. And within this interventricular septum, sulcus, we have also some blood vessels that runs like the descending, anterior descending artery or the posterior descending artery. So here you can see the external markings of the heart. So this will be the sulcus that we talked about. So this will be the atrioventricular sulcus with the coronary arteries. The other name for the atrioventricular sulcus will be coronary sulcus, just because these coronary arteries runs within this. And if you see here, you can see a layer of fat protecting this coronary sulcus. Now, I told you that more or less this runs a little bit horizontal, while this, which is the anterior interventricular sulcus, runs more or less vertical or a little bit angulated. And this anterior descending artery and other blood vessels runs through this sulcus. So since this is the anterior view of the heart and you're looking at external markings, so you will know then that here we will have the right ventricle. So in the anterior view, you can see more of the right ventricle, a little bit of the left ventricle, which is this. Of course, perfectly, you can see the apex in here, you can see the base, and you can see a lot of the right atrium with these extensions, which are known as auricles. And then here you have the left auricle of the left atrium. And then you see here the aorta, the pulmonary trunk, the pulmonary veins, the right and the left pulmonary veins, and then superior and inferior vena cava. Superior and inferior vena cava deliver the blood into the right atrium. The right and the left pulmonary veins deliver the blood into the left atrium. This is the posterior view of the heart with these markings. So in here still you see the coronary sulcus, and this will be the posterior interventricular sulcus with the posterior descending artery and the other blood vessels that runs in here. And then again, you see fat protecting all these blood vessels. As long as the fat is not inside the blood vessels, it doesn't matter, it's okay. Now here in the posterior view, you can see more of the left ventricle, a little bit of the right ventricle. You can see greatly the left atrium. You can see the pulmonary veins, how they deliver the blood into the left atrium. And then you can see a little bit of the right atrium with the attachment of the superior and inferior vena cava. And then you can see the pulmonary trunk, how it divides into the left pulmonary artery, which is going to deliver blood into the left lung, and then the right pulmonary artery, which is going to deliver blood into the right lung, and then this will be the aorta. Just to emphasize, the interatrial septum is the wall that separates the atria, the left and the right atria. And then within the right atrium and both articles, we have some parts of or ridges of myocardium that we know as the pectinate muscles. And then within the ventricles, we have this interventricular septum that separates the left and the right ventricle. And then within the ventricles, we have these muscle ridges that are known as trabecular carni that prevents the ventricular walls from sticking after contraction. So just to see a little bit of these details of the internal chambers of the heart, so these will be the pectinate muscles, and these will be the trabecular carni. Other feature that you can see in the ventricles will be the presence of these muscles, which are known as the papillary muscles. These papillary muscles helps to hold this cord of strings, which are known as cordae tendinae or tendinous cords. These tendinous cords, what they do is to hold the flaps or the cusp of the valves, preventing them from staying within the atria after the ventricles have contracted. Because when you are contracting these ventricles, which will be filled with blood, of course, you will create pressure, and that pressure is going to bring these flaps or cusps of the valves into the atria. And since you don't want to have all the time these cusps within the atria, you have to pull them back into the ventricles. So the function of these papillary muscles will be to contract, to create some tension within this cord of tendons or cordae tendinae, and then you pull back these flaps of the valve into the chamber, the lower chambers, which will be the ventricles. So let's talk about some details of the valves. The valves, the function will be to make sure that you have one-way flow of blood through the heart, always forward. And the atrioventricular valves or AV valves control the blood flow of the blood from the atria and the ventricles. Right atrioventricular valve again is called tricuspid. The left is also called bicuspid or mitral. And as I told you before, the cordae tendinae helps to prevent the prolapse of the AV valves into the atria. At the base of the pulmonary trunk and the aorta, you have the semilunar valves that controls the blood flow between the ventricles and the great arteries. On the right side, these valves, which are called semilunar because they have the cusp with half moon shape, the right side will be called pulmonary or pulmonic valve, and then in the left side is called the aortic valve. So this is the superior view of the heart, and then you can see here the AV valves. So in here you have 3 cusps. So these will be the AV valves, the largest ones. So this is the right side. This has three leaflets or cusps. 1, 2, 3. This is the tricuspid. And then in here you have 2 leaflets. So this will be the bicuspid or mitral. And then in here we have the semilunar valves. So these will be the aorta, and then this will be the pulmonary valve. And this pulmonary valve and the aortic valve, they have three leaflets, as you can see here, 1, 2, 3. And then in here, at the base of the aorta, you have the openings for the coronary arteries, which are these that provides the blood supply to the heart. Uh, this this blood flow is very important so that you can maintain the heart alive. And this is just a picture of a real aortic valve, so you can see it. This is the internal picture of the tricuspid valve at great magnification, so you can see the papillary muscle, the chordate tendinae, and the leaflets in here. So how does the blood flow happen through the chambers of the heart? So first you have to have, in order to fill the ventricles with blood, relaxation of the ventricles. So when the ventricles relax, they have a drop in pressure that makes these chambers to be filled with blood coming from the atria. And when this happens, your semilunar valves will close, preventing a continuous flow of blood into the either the aorta or the pulmonary trunk. Once you fill the ventricles with a specific amount of blood, you have a stretching of the muscle, the cardiac muscle. That is going to create tension in these muscle cells, and then the muscle cells suddenly will be contracting, and then you will have increase of pressure of the ventricles that is going to force the semilunar valves to open and the AV valves to close. So that will increase the pressure inside the ventricles. And this is exactly how the blood flow happens through the chambers, the diagram. So in here, you have in number 1, returning of the blood from the body. So if it's the inferior portion of the body, you will have blood coming from the, into the heart using the inferior vena cava. And if it's blood coming from the superior portion of the heart, meaning the anything from the arms and above, you have coming blood using the superior vena cava, and then you start here filling the right atrium. Once you fill the right atrium, you increase this pressure inside the atrium, and then this pressure is going to overcome the closure of this tricuspid, and then the tricuspid will open, and then you start filling the right ventricle with blood. And then once you have enough blood, you have contraction of the right ventricle, you will close the tricuspid, you will open the pulmonary valve, and then the blood will flow from the right ventricle into the pulmonary trunk. From the pulmonary trunk, the blood can follow two directions. It can go into, and it will go into the left pulmonary artery and into the right pulmonary artery to deliver the blood into the lungs. Once the blood is oxygenated in the lungs, the blood will return into the heart using the right pulmonary veins and the left pulmonary veins, reaching the left atrium. Once the left atrium is filled with blood, it will contract to open the mitral valve, and then the blood will flow from the left atrium into the left ventricle. Then once the left ventricle is completely full with blood, it will contract, and then you will close your mitral valve, open your aortic valve, and then the blood will flow from the left ventricle into the aorta, and then from the aorta will go into the different arteries that makes the different branches that will deliver the blood into our body. And then the blood will reach the tissues, it will oxygenate our tissues, then you will use this oxygen, the cells will produce CO2, that CO2 will be delivered into the venous blood, and then the venous blood will return into the heart using the superior and inferior vena cava, and then you start this cycle again. Before you deliver blood into any other tissue of the body, you have to provide blood supply into the heart first. Why? Because it's the organ in charge of delivering the blood into the body. So it is important to have enough oxygen, nutrients, etc., to be able to work to pump this blood. Sometimes I compare it to a cook that it is cooking at home. Okay, while this cook is cooking dinner or food for everyone, this cook is eating some of the food as he's preparing it. Why? Because he has to have the energy to prepare the food for the rest of the family. So then the coronary arteries will be the blood vessels that delivers then this blood into the heart. And 5% of the blood pumped by the heart is pumped to the heart itself, and the heart will sustain its strenuous workload because of this. And then you have pumping of blood about 250 milliliters of blood per minute, and it needs abundant oxygen and nutrients. So this will be how the coronary circulation happens. So here we have the base of the aorta, and then you have the right coronary artery or RCA, and then the left coronary artery or LCA. As the LCA is going towards the left and it's going to turn into the posterior part of the heart, it will change its name into circumflex. So posteriorly, you will call this artery circumflex. And then this left coronary artery is going to give an inferior branch that is going to go into this interventricular sulcus. This is going to be called anterior interventricular branch of the left coronary artery. And then as the right coronary artery goes to the right in between the atria and the ventricle in the atrioventricular sulcus or coronary sulcus, it will give this inferior branch that is called the right marginal branch of the right coronary artery. Why is called right marginal? Because this is the margin of the heart and this is the right side. So this is why it's called the right marginal artery. And then you can see it here posteriorly too. And this right coronary artery will continue as with the same name into the posterior heart, into the posterior side of the heart, and then it will give this branch, inferior branch, that we will be calling posterior interventricular branch. And then you provide the blood supply into the different segments of the heart, and then the heart will return the blood into these different veins. So here we have the posterior interventricular vein, here we have the left marginal vein, and then we have here the this small cardiac vein in here, and this great cardiac vein together with the anterior interventricular branch, and then all these veins will drain into this coronary sinus, and the coronary sinus can drain directly into the right atrium, or it can drain the blood first into the inferior vena cava and then into the right atrium. So the LCA gives several branches, anterior interventricular branch, as you already talked to you about this, the circumflex branch, and then they provide blood supply into different regions. The anterior interventricular branch or descending artery, which is the other name, anterior descending, it provides blood supply to both ventricles and to the two anterior thirds of the interventricular septum. The circumflex is going to supply blood into the left atrium and the posterior wall of the left ventricle. The right coronary artery is going to give blood supply to the pacemaker of the heart, which is known as the sinoatrial node and into the right atrium. And then the right marginal branch is going to give blood supply to the margin of the right atrium, so the lateral part of the right atrium and also the ventricle. And then the posterior interventricular branch is going to provide blood supply to the posterior walls of the ventricles and into the posterior third of the interventricular septum. And this is again just to show you all of these branches that we already talked about. So when you have contraction of the heart, at some point you squish a little bit the coronary arteries. So the coronary arteries during contraction of the heart, they don't receive as many blood as when the heart relaxes because it won't squish the coronary arteries as much. So once you have then this blood into the coronary arteries, the contraction of the myocardium will be compressing the coronary arteries and obstruct the blood flow, and then you will have to have relaxation of the heart muscle so you can have continuous blood into the coronary arteries. Now, the contraction of the heart is known as systole, while the relaxation of the heart is known as diastole. Okay, so some problems with the circulation of the heart. When you have obstruction, partial obstruction of these coronary blood vessels, you have less blood supply into the myocardium. Now, what can obstruct these blood vessels? Well, internally, it will be obstructed by blood clots or by plaque of fat, calcium, and fibrin. And this plaque that it forms start forming little by little, and depending on the degree of obstruction, it will be the lack of blood supply into the heart. Of course, if you have more obstruction, you have less blood supply, which is going to cause starvation of the cardiac muscle, which is known as ischemia. And this ischemia is going to damage this cardiac muscle, and then the cardiac muscle is going to release chemicals that is going to stimulate pain. And the myocardium will start shifting to have ATP formation into anaerobic fermentation, and it's going to produce lactate, stimulating more pain. When you have partial obstruction of the coronary arteries, is going to give this pain that we know as angina pectoris. Now, when you have complete obstruction, you have complete stop of blood flowing into certain segments of the heart, and then the cells of the heart, the cardiac muscle cells, will start dying, so you have an infarction, or what we call myocardial infarction or heart attack. This will cause death or necrosis of these cells, and depending on what area of the heart it is affected and how much tissue is affected is going to be the consequences. Sometimes the person cannot survive a single heart attack. Now, some of the characteristics of the heart attack is that the person will have a sensation of having heavy pressure or squeezing pain in their chest that irradiates or goes into the left arm, sometimes into the left side of the neck, and into the jaw. And some heart attacks may be painless, but it will disrupt the electrical conduction of the heart, so the muscle cells won't be able to contract, so the person will have a cardiac arrest. So MI is responsible for around 27% of all deaths in US, so it's very important. So 5 to 10% of the coronary blood drains directly into the heart, as I told you before, but the rest, they will drain into the superior vena cava. So great cardiac vein, middle cardiac vein, left marginal vein will drain into the coronary sinus, and then the coronary sinus will drain into the right atrium. Okay, now let's talk about the characteristics of the cardiac muscle. So the cardiac muscle cells are known as cardiomyocytes. This is a specialized type of muscle. The muscle is striated, so it has bands in their cells. And these cardiac muscle cells are shorter than the skeletal muscle cells. They are thicker and they are branched. And only they have a nucleus per cell. And within the cytoplasm of these cardiac muscle cells, we have this storage of glycogen. Now, whenever you have damage to the cardiac muscle, the cardiac muscle cells, they don't replace very easily. So most of the times, these cardiac muscle cells will die, and then you have replacement of these cardiac muscle cells by scars that we know as fibrosis. The cardiac muscle cells are constantly contracting, and they they require strong connections between them. These connections are known as intercalated discs, and they have interdigitating folds. They have mechanical and electrical junctions that helps them to contract synchronously, so they contract at once. So some of the characteristics of the mechanical junctions is that they are known as fascia adherence, in which you have these actin filaments that are anchored into the plasma membrane. And then each cell will be linked to the next via these transmembrane proteins that we know as desmosomes. And then these desmosomes will have this strong connection that prevents the cardiomyocytes from pulling apart every time that the heart contracts. Along with these mechanical junctions, we have electrical junctions known as gap junctions, which are like little windows that happens between the cells. And through these little windows, you have the transfer of ions like calcium, sodium, potassium. So you can have the same amount of calcium and ions across all the cells so that they can have this amount of ions at the same level, so you can have this perfect contraction in all these muscle cells. So this is a microscopy view of the cardiac muscle cells. So you can see these strong inner connections that we know as the intercalated disc, and these are short cells branched with a single nucleus per cell. So you can see this better magnification with better detail of the striations, the intercalated disc, the nucleus, and these cells, how they look branched. This is just to show you as well some of the glycogen storage that happens. Remember, glycogen is basically the storage of glucose. These cells are constantly 24/7 contracting, so they need to have this extra storage of glucose to have a contraction, to generate ATP. And then if you magnify this part of the intercalated disc, you can see these desmosomes, these connections, and then these fibers preventing these cells, neighboring cells, from pulling apart every time the heart contracts. And then you can see also these gap junctions that are like little windows that helps to make these transfer of ions across the cells. Okay, so before we move on into the next slide, let me tell you about the key points for this chapter. Some of the key points we will keep repeating them along the presentation, but let me tell you them. So the part of the muscle, heart muscle tissue, that transfers action potentials, ionic currents, and the force of contraction and electrical signals will be the intercalated discs. So basically, the intercalated discs have several functions like transferring action potentials, ionic currents, force of contraction, and electrical signals. Next key point will be that the right and the left pulmonary veins carry oxygenated blood into the left atrium of the heart. The next key point will be that the right ventricle, pulmonary trunk, and the left atrium form part of the pulmonary circuit. So again, right ventricle, pulmonary trunk, and left atrium form part of the pulmonary circuit. Now, this next key point, we will see it now and also in the future in the development chapter. So there is this normal communication between the right and the left atrium in the fetus. So during fetal life, the right atrium and the left atrium communicate through an opening that we know as foramen ovale. F-O-R-A-M-E-N. Foramen. And then ovale will be O-B-A-L-E. So this foramen ovale allows blood flow from right and left atrium. The next key point will be that the right side of the heart carries oxygen rich blood and the left side of the heart carries oxygen poor blood. This is a false statement. So the right side of the heart carries oxygen rich blood and the left side of the heart carries oxygen poor blood. This is a false statement. Next key point is that the pulmonary veins carry oxygen rich blood into the left atrium. Next key point. The part of the EKG or electrocardiogram that represents the depolarization of the ventricles is the QRS complex. QRS complex. The next key point is that the left atrioventricular valve, it is connected to the, it is also known as mitral valve, that the left atrioventricular valve is also known as bicuspid valve, and that the right atrioventricular valve is also known as tricuspid. The last key point is that the conducting system of the heart follows this sequence of excitation. So the conducting system excitation happens first at the sinus node or SA node, and then from there it will go into the AB node or atrioventricular node, and then from there the excitation will go into the AB bundle, and then from there the excitation will go into the bundle branches right and left, and then lastly the excitation will reach the Purkinje fibers, P-U-R-K-I-N-G-E fibers. Okay, so the heart metabolism. So the cardiac muscle depends almost exclusively on aerobic respiration to make ATP. And the heart uses this glycogen storage, and it is rich in mitochondria because mitochondria is part of the aerobic respiration system that makes ATP. So the heart cells have as many mitochondria that fills 25% of the cytoplasm. And the heart, it is at some point when it runs out of glycogen, not so picky. So it can use other fuels to generate ATP like fatty acids, glucose, ketones, lactate, and amino acids. And this heart, since it's very active, is very vulnerable to deficiency of oxygen. Now, this heart muscle is fatigue resistant, and it makes little use of anaerobic fermentation or oxygen depth mechanism, so it doesn't fatigue for a lifetime. Okay, so the conducting system or conduction system of the heart. It is a specialized system that coordinates the heartbeats. These cells have an internal pacemaker that have nerve-like conduction pathways through the myocardium. So these are nerve-like cells, and these cells generate and conduct these electrical signals or action potentials in the following order, the order that I already told you. The SA node starts with this excitation. The SA node is located at the right atrium just by the base of the superior vena cava. From there, the SA node, it will spread the action potentials into the atria, and then the excitation or the action potentials will reach the AV node. The AV node is located at the top of the interventricular septum, and then from there, the AV node will extend some fibers that are known as the AV bundle or bundle of His, atrioventricular bundle. And then the atrioventricular bundle will branch into the left and right bundle branches, and then from there the bundle will spread into the apex, and then from the apex the fibers will go up to form the Purkinje fibers. So this is the diagram to show you the spread of the action potentials or the excitation within the different parts of the conduction system of the heart. So action potentials that helps for the contraction of the myocardiocyte starts at the pacemaker, which is the SA node. And then from the SA node, the action potentials will spread into the atria. And then you will reach the atrioventricular node or AV node, and then from the AV node the action potentials or excitation will travel into the AV bundle, which is this. And then the AV bundle will divide into the right and left bundle branches that reaches the apex of the heart, and then these will extend up into the walls of the ventricles, forming what we call the Purkinje fibers. Now the heart it receives also innervation or nerve supply by the ANS, autonomic nervous system. So it will receive this supply by the sympathetic branch of the ANS, and this sympathetic branch is going to increase the heart rate and the contraction strength of the heart. So you increase contractility and heart rate. Now regularly we have between 70 to 80 beats per minute, but when you have the action of the sympathetic nerve on the heart cells, you will have an increase of the heart rate that it can be over 100. And then when you have over 100 beats per minute, that will be called tachycardia. Now specifically, the name of these sympathetic nerves that supply the heart is called the cardiac plexus of the heart. The other branch of the ANS, the parasympathetic fibers or nerves, also innervates the heart, and it will have opposite effect to the sympathetic system. So the parasympathetic system through the vagus nerve will decrease the heart rate, so it will cause bradycardia. Now, when the heart contracts, it is known as systole. When the heart relaxes, it's known as diastole. So you can have atrial systole, atrial diastole. You can have ventricular systole, ventricular diastole. Now, the heart is supposed to beat at regular intervals of time. And this is provided by a functional conducting system. And more or less, we have one heartbeat every 800 milliseconds. So we will have around 70 to 80 beats per minute thanks to the vagal tone. because actually the SA node, it is very potent when it's generating, auto-generating these action potentials. That's why it's called the pacemaker of the heart. This SA node will generate like around 100 beats per minute itself if we didn't have the action of the vagus nerves. So when you have the action of the vagus nerves, you have reduction of that heart rate from 100 beats per minute to 70 to 80 beats per minute. So if the SA node will be damaged, as it happens in some cases, the next part of the conducting system that will make the heart to beat, it will make the heart to beat at a lower rate. So the AV node will take the lead for being the new pacemaker of the heart, and it will make the heart to beat between 40 to 50 beats per minute. And then after that, when you if you have damage of the AB node, um, then the AB bundle or the bundle branches or even the Purkinje fibers can take over for the contraction of the muscle of the heart. But every time that you go down the ladder of this conducting system, you have less and less beats per minute. So that's why it is very necessary when someone has a block, which is one of the kind of names for the conditions when you have damage to the conducting system. When you have block, to check which node is damaged, and depending on what is the condition, you can give drugs or you can replace the pacemakers. So the SA node does not have a stable resting membrane potential. So this SA node will have leaky channels for sodium. So as the sodium is rushing into these SA node cells, you have gradual depolarization. And this starts at minus 60 millivolts, and then it will start reaching less and less negative voltage up to minus 40, in which you reach the threshold, and then you have a fast depolarization that will peak at 0 millivolts, and then you will have this closure of the sodium channels and then opening of calcium channels, so you can sustain a little bit the depolarization that happens, and then suddenly you have closure of these calcium channels, you have opening of these potassium channels, and you have exiting of the potassium from the cardiac muscle cells. You have rapid repolarization, and then you return into the minus 60 uh, resting membrane potential, and then you start the cycle again for producing this excitation. So this is how the action potential looks like in the pacemaker cells. So you start here with this resting potential at minus 60. You have these leaky channels of sodium that allows the slow influx of sodium, causing gradual depolarization until you reach this threshold, minus 40. And then you have sudden open of the rest of the sodium channels and the calcium channels. You have influx of calcium and sodium, and actually you have also release of calcium by the sarcoplasmic reticulum in the heart. So then you have this rapid depolarization that reaches 0 millivolts, and then you have a little bit of sustained uh, depolarization because you still have calcium within the cells, and then you close these calcium channels, potassium channels, sodium and calcium channels, and then you open your potassium channels. You have outflow of the potassium, you have rapid repolarization, and return to the resting potential of the pacemaker cells, and then you start over again. Okay, so then the signals will travel very quickly from the different regions of the conducting system, so that you can have efficiency in the contraction of the myocardium, and then you can have synchronization of these cells contracting all at once, preventing different segments of the heart contracting at different times and then having unwanted mixing up of the blood. Now the cardiomyocytes, they have also their own resting potential at -90, and they only depolarize when they are stimulated by the conducting system. Now in the case of the myocardium, the depolarization is very short, and then the action potential peaks up to +30, and you still have a plateau that it is actually between 200 to 250 milliseconds, because you have this opening of these calcium channels that are located within the sarcoplasmic reticulum, and these calcium channels will make this storage of calcium that you have in the sarcoplasmic reticulum to leave the SR, the sarcoplasmic reticulum, and then you have a lot of calcium inside the cells, which, since it's positively charged, will sustain uh, this plateau. And then the repolarization happens when you close, similarly as to the pacemaker cells, you close the calcium channels, and then you close your sodium channels, you open your potassium channels, and then you have exiting of potassium outside the cell, and you have returned to the resting membrane potential to -90. And then within the heart, you have a long absolute refractory period, which is 250 milliseconds, that prevents this contraction of the heart cells when it's not needed. And this is a very long refractory period in comparison to the one on the skeletal muscle. So this is the comparison then for this action potential that happens during the contraction of the heart. And then you can see this plateau here caused by the calcium channel to be open and the calcium presence in here. And you have here this rapid repolarization, and then you have this slow depolarization. And then the myocardial relaxation happens at this point in here. You study the electrical activity of the heart with the electrocardiogram, EKG or ECG. And these electrical signals can be detected using this EKG machine that connects electrodes placed on the arms, legs, and the chest to this machine, and then you receive this electrical signal that will be recorded in a piece of paper. So these will be the different deflections on the piece of paper that are recorded, and that it pinpoints to different electrical activities of the heart. So within the electrocardiogram, you have this baseline, and then anything above this baseline will be positive waves, and anything below will be negative waves. So the first wave that you see here, which is known as the P wave, corresponds to the atrial depolarization. So when the atria becomes positive. And then you have this PR interval that pinpoints to the time that it takes for the action potential to travel between the SA node and the AV node. And then you have this negative deflection that is called the Q wave. Then you have a positive that is known as the R wave. And then you have a negative deflection that is known as the S wave. All these three, the Q, the R, and the S, form a complex that we call the QRS complex. This points to the ventricular depolarization, or when the ventricles become positively charged. And then you have this T wave, that it is a positive deflection that pinpoints to the ventricular repolarization. Now, the QT interval is the time that it passes when the ventricles contract. And The PQ segment is when the atria contract, and then you have the ST segment that is part of when the ventricles contract. Now within the QRS, you have this separation between the two R waves that help you to count the number of beats per minute. So you have these little squares within this piece of paper, and then you have also large squares. And you have to count the number of large squares between the two R's if you have a regular rhythm, in which in this case you see it because you can see the P waves at regular intervals of time, which in this case will be 0.8 seconds. So if you count the number of big squares in between the two R's and you divide them by 300, you will get how many beats per minute you have. So for instance, if you find in an EKG 4 big squares in between two R waves, that means that you have 75 beats per minute, because if you divide 300 by 4, that will give you 75. So I already told you what each of these waves or segments mean in the EKG, so let's skip this. So this is what happens when you have these different signals in the EKG. So this P wave corresponds to the atrial depolarization. So any depolarization, you can see it in red color. Any repolarization, you see it in green color. So in here, the atria starts to depolarize, so you form the P wave. And then the QRS forms when you have this ventricular depolarization. Okay, and then this P, QRS, and T means that the T is repolarization of the ventricles. Now, why you don't see the repolarization of the atria? Well, it's because it happens when you have the QRS. So the QRS, it is obscuring, the QRS complex is obscuring the the atrial repolarization. We study these EKGs to find some deviations from the normal that can indicate either myocardial infarction, possibly ischemia in the case of angina pectoris, or any abnormality in the conduction system, which basically you will find irregular intervals of time between the P waves or the QRS, etc. And then you can pinpoint also enlargement of the heart because you have elongation of these ST segments, etc. Or you can also find electrolyte or even hormonal imbalances. So in here it shows you what does an EKG normally look like and what an abnormal EKG look like. So in any normal EKG, you can see the P wave always preceding the QRS, the T wave after the QRS, and always regular intervals of time between these QRS. And the big squares or the large squares are found in between the bold lines, as you can see here. And then inside this big square, you have small squares. And each of these big squares can be counted in between these two regular R's. So if you see here, you have a little bit over 5 large squares in these two R waves. So what will be the heart rate in this case? So divide 300 by 5. And let's see how many beats per minute did you get? Okay, so if you have 60, That will be the approximate heart rate. Because if you divide 300 by 5, that will give you 60. So it's 60 beats per minute. And this is known as sinus rhythm, normal. Why sinus? Because you have the P wave preceding the QRS, and then in here you have what we call ventricular fibrillation, in which you have abnormal contraction of the heart. Okay, so the cardiac cycle will be a complete systole and diastole, or contraction and relaxation of all the 4 chambers of the heart. And then some questions to consider will be, how does the pressure affect the blood flow, and how does the heart sounds are produced? So there are 2 main mechanisms that makes the blood to flow within the heart. So you have the pressure that causes the flow of the blood and the resistance that opposes the flow of the blood. And whenever you have a difference in pressure within the different chambers or the different segments of the circulatory system, you will have blood flow. So you will have a gradient or a pressure difference. If there is no pressure difference, if you have the same pressure on 2 different segments, there won't be any flow of blood. Sometimes I compare this to when someone is trying to push another person, and this person is the same weight, and they don't fight, they don't wrestle, simply they're just trying to push each other. But if they're the same weight, they won't move as much. But if someone is lighter in weight than somebody else, then of course there is a difference, there is a gradient, and then the heavier person is going to push the lighter person. Okay, so that's a difference. And then the pressure is usually measured in millimeters of mercury, and it is measured with a manometer or sphygmomanometer. So at some point, well, this diagram is showing you, or this figure is showing you how you have to have a difference in pressures for flow to happen. When you're pressing this little handle in a syringe and you apply pressure, you overcome this pressure one in here. So you have to have greater pressure in here as you're pressing in here than in here to have flow of fluid outside of the syringe. So regularly our blood pressure will be 120 over 80. 120 will be for normal pressure, will be systolic pressure, and 80 will be the diastolic pressure. So when the left side of the heart relaxes and expands, its internal pressure falls. And then the mitral valve is open, and then the blood flow into the ventricle, from the atria into the ventricle. When you fill this ventricle with blood, the pressure inside the ventricle will increase, and then you will contract the walls of the ventricle, you will close the AV valves, you will produce the first heart sound, and then you open the pulmonary valves, and the blood will flow from the ventricles into the aorta and into the pulmonary trunk. Now, every time that you open the valves, you don't produce any sound because this is more a passive event. But when you close the AV valves, you produce the first heart sound that is known as S1. This is the loudest sound of the heart. This will be the lub. And then when the blood goes into the aorta or into the pulmonary trunk, you will increase the pressure in these blood vessels. And then this will allow the closure of the semilunar valves. So when the semilunar valves close, you have the production of sound of the heart, the second sound, or S2, the dub sound. So you have lub dub, lub dub, lub dub. Okay? So this is how the valves open and close. So they open when you have higher pressure proximally to them, and then they open, allow the flow of blood from upper chambers to lower chambers. These lower chambers get filled with blood, blood pressure increases. These will close these AV valves. You have S sound, S1 sound produced, and then you will force the blood into the pulmonary trunk or the aorta because you have more pressure in the ventricles than in the arteries. And then as the ventricles are getting emptied, and then you have the blood inside the aorta or the pulmonary trunk, you have increased pressure in here, which closes the semilunar valves. You produce the second sound, the S2 sound, and then you have your lub dub. If you want to believe me this of the closure of the valves producing the sound, it's like when you open a door. When you open a door, if you have not squeaky this well, if you don't have squeaky doors, you know what I mean. So if you open the door, you don't produce any sound. But if you are mad or someone is mad and slams the door, that's when you produce a sound. So that's what it produces, the heart sounds, when you close the valves, not when you open them. In order to hear the heart sounds, you will use an stethoscope, and then you perform auscultation of the heart, and you can hear the S1 and the S2 sounds. And the S3 sound is an extra sound that is rarely heard in people over the age of 30. Now, some of the phases of the cardiac cycle involve ventricular filling that happens during diastole, and then you have contraction of these ventricles into what we call isovolumetric contraction. And then you have ejection of the blood into what we call ventricular ejection, and then you will relax your ventricles into what we call isovolumetric relaxation, and then all the four phases will complete in less than 1 second, around 800 milliseconds. So as the ventricles expand, their pressure drops below that of the atria, and you have this ventricular filling. Now you have a rapid ventricular filling that happens in the first 1/3 of this phase, and then you have something that is called diastasis in the second 1/3, that it is known as slower filling, and this is when the P wave occurs. And then you have on the last third the atrial systole or atria contracting, and then that will reach the entire volume that the ventricle can hold, which is 130 milliliters of blood, into what we call the end diastolic volume. After this, you have your isovolumetric contraction that corresponds to the QRS, and you will have also the formation of the S1 sound. And then it's called isovolumetric contraction because as the ventricles are contracting, they do not eject blood. And then you have increase of the pressure as this pressure increases during this isovolumetric contraction, and then you will open the semilunar valves, and then you will eject the blood into what we call ventricular ejection. Now, this ventricular ejection will peak at 120 millimeters of mercury, and this will be on the left ventricle and 25 in the right ventricle. Now, you have in this ventricular ejection a rapid ejection, and then you'll have a reduced ejection. And this phase will last 1/4 of the complete cycle, which will be around 200 to 250 milliseconds. And then you will have the plateau phase of the cardiac contraction, the one that we saw where you have calcium. And in this case, the T wave will happen later during this phase, and you'll have ejection of blood every time that your heart contracts, and this will be called SB or stroke volume. And this SB or stroke volume is 70 milliliters. And the ejection fraction, which is 54% of the end diastolic volume, is 130 milliliters. And 60 milliliters will remain inside the ventricle. So this will be the end systolic volume. So at some point, the ventricles are not completely empty every time. So they have to have a certain volume that it is known as end systolic volume or ESV, which corresponds to the end diastolic volume minus the stroke volume. So if you subtract 130 minus 70, that will give you 60 milliliters that you still have in the ventricular ejection phase. And after this, you will have the isovolumetric relaxation, which corresponds to the T wave, and you will have expansion of the ventricles because you don't have any more volume, and then you have the heart sound S2 happening, and it is called isovolumetric because the semilunar valves will be closed and the AV valves have still not yet opened. And when this happens, the ventricles cannot take more blood because the AV valves are closed, and when the atria has more blood delivered into them by the superior vena cava, inferior vena cava, or by the pulmonary veins, you will increase the pressure of the atria, then you increase the pressure in the atria, then the AV valves will open, and then you start the cycle again. Now, in a resting person, the systole of the atria will last 0.1 seconds, while the systole of the ventricles will last 0.3 seconds. And then you have a period that is called quiescent, in which all the chambers are in diastole and last around 0.4 seconds. So at some point, the heart spends more time in in diastole or resting than in systole. And this is important because it allows the heart chambers to fill. And this figure, it shows you how you have changes in pressure that is shown in here during systole and diastole. And that corresponds to these different cycles in this cardiac cycle or parts of the cardiac cycle that I already mentioned. So this is the overview of the volume changes that happens within the heart. So you have an end systolic volume of 60, and then during the ventricular filling that happens, you will have plus 30 milliliters of blood added, and then you add more during atrial systole, so that's plus 40 milliliters to have a total end diastolic volume of 130. And during ventricular ejection, you have minus 70 milliliters of blood to leave 60 milliliters of blood within the ventricles. And then independently, whether it is the right or the left ventricle, both of them, they will eject the same amount of blood, which will be the stroke volume, minus 70 or 70 milliliters. Now we have another term in here which is called the cardiac output. So the cardiac output will be the amount of blood that the heart ejects per minute. And the cardiac output can be calculated multiplying the number of heartbeats per minute or the heart rate times the stroke volume. So more or less the cardiac output in someone can be between 4 to 6 liters per minute at rest. Of course, if someone is doing vigorous exercise, the person has to have an increase in the cardiac output to supply the demand of oxygen by the cells. So all you need to do now when you were asked for calculating the cardiac output is to have the number of heartbeats per minute and multiply it times the stroke volume that it is given to you. So if you have a heart rate of 70 and you have a stroke volume of 70 milliliters, you multiply it 70 times 70 and that will give you your cardiac output. Now, another term that is here is cardiac reserve, which is the difference between a person's maximum and resting cardiac output. This cardiac reserve will increase with fitness and it will decrease with disease. Now, pulse refers to the surge of the pressure that is produced by the heartbeat that can be felt by palpating a superficial artery. The arteries that usually we use to feel the pulse will be the radial artery in your forearm. We can use also the carotid artery on the sides of the trachea. We can also use uh, the tibial artery in our legs, the popliteal artery in the back of our knee. We can use the temporal artery in the temple. We can use several pulse points. Now, the infants, they have a higher heart rate than the adults. They have 120 beats per minute that you can feel in the pulse. Young adult females between 72 to 80, males between 64 to 72. And at some point, the heart rate usually rises in the elderly and it decreases in athletes. Tachycardia will be having a heart rate above 100 beats per minute, while bradycardia is having a heart rate of less than 60 beats per minute. At some point, bradycardia can be relative. So some athletes can have 55 beats per minute and they don't faint. Why? Because their heart is so powerful that it doesn't necessarily need to have a lot of heartbeats to deliver the same amount of blood as the persons uh, who are not athletes. And then the heart can be subject to something that is called positive chronotropic agents, which are factors that can increase the heart rate, and negative chronotropic agents that are factors that lower the heart rate. So the ANS can have a chronotropic effect. So if you remember, sympathetic system increases the heart rate. So it has a positive chronotropic effect because it's increasing the heart rate. But also you can have a negative chronotropic effect with the vagus nerve. The vagus nerve decreases the heart rate. Drugs like adrenaline or epinephrine increase the heart rate, so they have a positive effect. So they increase the heart rate. And they do so because within the heart cells, we have some receptors that are called beta adrenergic receptors that increases the contractility of the heart and increases the heart rate. Why? Because it helps to increase the opening of calcium channels within the plasma membrane, so you have more calcium available for contraction. And then you have drugs that have a negative chronotropic effect, like beta blockers that decrease the heart rate and the contractility of the heart. So the parasympathetic system, the vagus nerves, decreases the heart rate because it inhibits the SA node and the SAB nodes because it releases acetylcholine, and this acetylcholine, which is a neurotransmitter, will bind to the muscarinic receptors within the SA node and AV nodes, which opens the potassium channels, and the potassium will leave the cells, leading to hyperpolarization that makes the cells less likely to become excitable. So you decrease the heart rate. So without the influence of the sympathetic system or the parasympathetic system that are found in the cardiac centers within the medulla oblongata, the heart rate will have an intrinsic firing rate of 100 beats per minute. Why? Because the SA node will send the signals for a heart to contract 100 beats per minute. And then we, we will have this vagal tone that decreases the heart rate to 70 to 80 beats per minute. So some of the inputs to the cardiac centers in the medulla are diverse. That includes signals coming from the cerebral cortex. So if you are scared, you will increase the signals from the cerebral cortex, sending signals into the limbic system, into the hypothalamus, and then into the medulla oblongata. So you can increase the heart rate through the sympathetic system nerves. And then you also have receptors within the muscle, the joints, the arteries, brainstem that can increase the heart rate. Along with that, we have the baroreceptors that signals the cardiac center through the glossopharyngeal nerve, for instance. So we have these baroreceptors in the arch of the aorta, within the internal carotid arteries, that when you have a decrease in the blood pressure, you send a signal also through this vagus nerve that can drop the well, when you have a drop in the blood pressure, you have a signal rate drop, so your action potential become less. That will send a signal to the cardiac center to increase the heart rate, and if the blood pressure increases, will be the opposite. So the action potential rate increases, the cardiac centers will be inhibited, so you will decrease the heart rate. Along with that, your cardiac centers receive input also from chemoreceptors. So we have these chemoreceptors, again, similarly as for the baroreceptor, we have it in the arch of the aorta, the carotid arteries, the medulla oblongata, and also within some centers within the brain that receives signals about the amount of hydrogen ions that we have, so detects the blood pH, also the levels of CO2 and oxygen. And depending on what is the problem, it will be the effect. So for instance, when you have high levels of CO2 or hypercapnia, you have acidosis. This will increase the heart rate and also will increase the respiratory rate, so you can exhale that CO2 and then you can return to normal levels of pH, to neutral levels. Okay, and also you can have both of them working together, the baroreflexes and chemoreflexes, that helps to prevent sudden changes in the blood pressure or sudden changes in the chemicals within our body, to prevent so many swings in homeostasis. So again, the neurotransmitters norepinephrine and acetylcholine can affect the heart rate. Neurotransmitters like epinephrine increases the heart rate, while acetylcholine decreases the heart rate. Another other chemicals like thyroid hormone or caffeine increases the heart rate too. Electrolytes can have also a chronotropic effect, like if you have excess of potassium or hyperkalemia, your myocardium is less excitable. And if you have hypokalemia, your cells are hyperpolarized, so you will have to have an increased stimulation for having the normal contraction of the heart cells. Calcium, if you have hypercalcemia, you will have decrease of the heart rate and the contraction strength. If you have hypocalcemia, you increase the heart rate and the contraction strength. So things that affects the stroke volume or the amount of blood that is pumped by the heart every time that it pumps. It will be how much blood return you have or the preload, how strong the contraction of the heart happens or contractility, and how much resistance you have in the different blood vessels that attaches to the heart. This is the afterload. So some examples will be when you have increased preload, so when you have more blood volume coming, or when you have more contractility, you have more stroke volume, so you pump more blood. If you have an increased afterload, so if you have increased peripheral resistance of the blood vessels, you will pump less blood into your heart, into your body. I already explained you what is preload, so basically will be the amount of blood that returns to your heart that will generate certain amount of tension within your cardiomyocytes, and it will influence the rate and the strength of contraction. The heart the heart cells will contract because there is a law that is called Frank-Starling law that it's basically related to the stroke volume that is directly proportional to the end diastolic volume. So when you have an increased end diastolic volume, you will have a stronger stroke volume. So the more blood that you have in your ventricles, the more stretched that your muscles will be and the harder the muscles that they will contract. And that will be up to a certain point because there's a limit. Okay, not because you overflow the ventricles with blood, that means that your heart will be super contracting. No, there is a limit so for the muscle cells to contract. And then contractility will be referring to how hard the myocardium will contract. You can have more contraction when you have positive inotropic agents like hypercalcemia, catecholamines like epinephrine or epinephrine, glucagon, and some drugs like digitalis that increases intracellular calcium. So at some point, anything that increases calcium levels can increase contractility. And then you can have these negative inotropic effects that are related sometimes to the low levels of calcium like hypocalcemia, high levels of potassium like hypercalcemia, or when your vagus nerves don't work as well, and then you have less contractility of the heart. Afterload will be the sum of all forces opposing ejection of blood from the ventricle. So it will be basically the sum of all the resistance within the arterioles within our blood, within our circulatory system, and then that can lead to hypertension, which is basically a force that opposes blood flow or ventricular ejection. So the afterload will be anything that impedes arterial circulation. For instance, you can have lung diseases that impedes pulmonary circulation. You can have something that is called cor pulmonale, in which the right ventricle fails to pump blood into the pulmonary circulation because you have chronic bronchitis, emphysema, or blocked lung disease, fibrosis within the lungs, or resistance within the lung tissue. Okay, so what is the relationship between exercise and cardiac output? So exercise will make the heart to work harder because you need more oxygen. As your cells become more active, you require more oxygen. And the exercise will increase your cardiac output. Now, so you have within your muscles, within your joints, proprioceptors that will send this signal to the cardiovascular centers that will help to send this sympathetic output so you can increase heart rate, heart contractility, and consequently cardiac output. So you will pump more blood per minute. And then along with that, you have more blood return or more preload into your heart. That ultimately will increase, of course, cardiac output. So, as summary, increasing the heart rate and the stroke volume increases the cardiac output and vice versa. And exercise also increases ventricular hypertrophy. So, increased stroke volume will allow the heart to beat more slowly at rest. And in athletes with increased cardiac reserve, they can tolerate more exertion than a sedentary person. So lastly, let's talk about CAD or coronary artery disease. In this case, you have an obstruction of the coronary arteries. The most common cause of obstruction will be atherosclerosis, which is having a plaque made out of lipids, calcium, and fibrin. These lipids will decrease the lumen or the opening within the coronary arteries, and it will decrease the blood flow into the myocardial cells. Most of the times, the coronary artery disease starts with a damage to the endothelium because someone might have hypertension, diabetes. But as we age, at some point, we all will start developing atherosclerosis. Now, when you have this endothelial cell damage in the coronary arteries, you have the monocytes penetrating the walls of these damaged blood vessels, and they will form these macrophages. These macrophages will absorb cholesterol and fats, and they will form some cells that are called foam cells. And then you will have the formation of this plaque or atheroma. Along with calcium and fibrin, you have also platelets adhering to this damaged area, and then you have attraction of the immune system cells and mitosis of the smooth muscle and fibroblasts and the position of collagen within these coronary arteries, and then you will have this mass that bulges towards the arterial lumen, obstructing more and more every time the coronary arteries. If someone has around 75% of obstruction of these coronary arteries, the person will start developing first angina pectoris. And if the person has an spasm of the coronary arteries that are obstructed because the person is under stress, the person will have more reduced lumen, and then the angina pectoris will be more severe. At some point, if someone has a blood clot form in another part of the body, and this blood clot migrates and form an embolus, this embolus can go into this coronary artery and it can completely occlude it, and then the person will have a myocardial infarction. So there are major risk factors for CADs, like increased levels of bad cholesterol, that is called LDL. Also, the person might have dysfunctional receptors in the arterial cells, cause them to accumulate excess of cholesterol. The person might have inheritance for having CAD. As we age, we have more chances of having CAD, and males do have more chances of having CAD because estrogens in females have a protecting property for preventing us from having CAD. Now, females after the reproductive stage in menopause, they have increased chances of having CAD because their estrogens drop. And we have also risk factors like obesity, smoking, sedentary life, anxious personality, aggression, etc., that predispose the person to have CAD. Now, these are preventable factors, these last ones. If you have genes for CAD, if you are aging, and if you're male, those are not modifiable factors, so you have to live with those. And at some point, if 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 you have a bad diet, if you're not very active, etc., if you're stressed, you can modify these factors, and then you can prevent CAD much easier. Speaking about stress, if you have a stressful personality or if you are very anxious, please calm down in this class, as I don't like so much to be having persons who are stressed without any cause in this class. Okay, so treatment for CAD, if the person has really obstructed coronary arteries, the person can have a bypass surgery in which they can uh, perform a surgery in which they place a piece of the greatest saphenous vein or any small thoracic arteries into the heart to prevent this obstruction from happening. Also, you can introduce a catheter with a balloon on the tip and inflate this balloon to decrease this plaque inside the coronary arteries. You can do laser angioplasty, or you can insert a stent to prevent this narrowing of the coronary arteries. So this concludes this video lecture. Hopefully you have enjoyed it, and if you have any questions, email me. And so for some of you, have a good day or have a good night. Bye bye, and remember, don't be stressed.